Thank you so much for taking the time to hear my lecture called The Science of Changing Clinical Practice and Culture. This is a reprise of the BJS lecture that I gave at the ASGBI 2025 meeting. These are my disclosures. Some of this work does fund the work that will be presented here today, but there are no off-label topics or personal investments to discuss. One more disclaimer before I do give my talk. The world has changed a bit, and you'll see what I'm talking about more towards in the second half of my talk, and that these views are my own views and do not represent the institutions, organizations, or programs that I am affiliated with. So a little bit about me. Who am I? I think it's really important to get to know a little bit about the person whom you're going to hear a lecture from. I grew up outside of Philadelphia and did both my medical school and my undergraduate there. I then went up to New York City, where I completed my surgical residency and subsequently went to Boston for my fellowship in minimally invasive and bariatric surgery. After an initial few years in New York City, I found myself moving to Michigan, which was really interesting, as I don't think I could have pointed Michigan out on a map. So I'm going to make sure to point that out on the map for you today, and found out a little really wonderful things about the state. Really, its culture is beyond belief. There's many beautiful parts of it that rival some of the prettiest areas anywhere in the country or abroad, and that there's an extraordinarily and deep-rooted history in Detroit in the auto industry and other areas. And where I landed for my work every day is at the University of Michigan, which is located in Ann Arbor. And I kind of divvy up my day and my thinking into four critical processes. One is I have a leadership hat where I serve as the section chief for general surgery at the University of Michigan in our Department of Surgery. Our section's a large section and it's broad. We have about 52 surgeons within the section who basically cover the gamut of surgical practice, whether it's surgical oncology, endocrine, hepatobiliary, trauma, acute care surgery, minimally invasive surgery, bariatrics across multiple sites. And it's my honor and privilege to get to work with these colleagues every day and thinking about how to continue to push us forward. My clinical practice as an active clinical surgeon is in minimally invasive therapies for treatment of obesity and for hernia repair. I do a fair amount of research, and much of that research is in what I'd like to call implementation science, which is essentially the study of behavior change and figuring out multi-pronged strategies to promote adherence to evidence-based medicine, whether it's in hernia, which we'll hear a little bit about today, or in areas of inequitable achievement across medicine, which we'll hear about as well. And finally, in education, we are very proud to boast one of the largest training programs in general surgery, and we have been number one on Doximity for the last 5 years, which has been a real tremendous feat and a testament to our program's leadership, as well as the culture of education and learning fostered around me. I feel very fortunate and blessed to be part of this community every single day. So where do we start? The way that I kind of boil down my career and things that I think about is how do we affect change in surgery to improve care? And I think of this in terms of the quadruple aim that many times we hear about: improved clinician experience for better outcomes, lower costs, and improved patient experience. And there are many factors that are required to do this, but many of them are overlooked. Simply strategies for dissemination and implementation, as well as attention to workforce. Strategies for implementation and dissemination can often be seen where in the US we have about a 17 to 20 year lag between the implementation of evidence and its actual use in practice. So it can take anywhere from someone generating some level 1 evidence of something that's really important to do, and you would think that this would be uptook, whether it's a guideline or a recommendation, but it can oftentimes take forever, and this is multi-pronged and multifactorial. And then in terms of workforce, that's really the underpinning. And a lot of times we've had different issues in terms of what we model as leadership, what we model as important, and whether or not that really encourages a workforce that represents our patient population. And to fall in line today, I'm going to talk about two examples that really are on those overlooked domains. One is in the adherence to evidence-based hernia practice at scale. And then the second is really the mitigation of gender equity locally and at scale. So let's talk about this in a unified framework, because I think oftentimes we view issues in workforce versus actual work or clinical work as different things. But the key tenet and the central force that unifies my talk is really that the same frameworks that we think about, adherence to evidence-based care, using implementation and rigorous frameworks, are the same ones that we can apply to other domains. So how do we leverage implementation science? Well, in implementation science, we typically rely on many different frameworks to organize our thoughts and to create the strategies that we need for change. And these frameworks really are at many different levels. You have organizational frameworks, system levels, and individual frameworks. The framework that I've selected for much of my work is really a framework that works at the individual level, because at the end of the day, as surgeons, many of the decisions that we make are individuals. And that does not mean that the strategies that we deploy don't live at those other levels. But the question is where is the behavior change that you want to see? And because of this theoretical domains framework really has helped facilitate evidence-based surgical practice, and is pretty reproducible in terms of the various steps. Step one, really identifying your practice gap. Step two, looking at the evidence-based innovations to reduce the gap, determining their barriers and facilitators, linking those to behavior change techniques, and finally designing overcome barriers. And why this is important is I think historically, at least in the United States, we have a one-size-fits-all model. So for instance, hand washing. Nobody's going to argue with us or say that hand washing isn't very important. And oftentimes this is monitored, it's monitored in hospitals, and there's a lot of disincentives around not washing hands. And, you know, if you want someone to wash your hands and you create a solution to do that, which is involving penalizing them for not doing, and anytime they don't wash their hands, they're going to get 10% of their pay doc. Well, that's great. But what if the problem is that they didn't have a sink? And it's really that inattention and the malalignment with either the benefits or the barriers in the actual practice that kind of limit their adoption. And we have to start thinking multifactorially. And I think this is really important in hernia repair. And so a lot of times, many of these strategies have been leveraged really more in the oncologic space. And a lot of times these, what I call sometimes throwaway conditions, are often ignored. But hernia is an excellent example of a preference-sensitive condition that impacts over 1.6 million persons in the US. It's costing over $3 billion per year in healthcare and associated expenditures, and it's morbid. 1 in 4, 1 in 5 persons will experience an adverse event, and it's been overlooked. And so the big thing is also with hernia that it's not just about the short-term complications that we think about, but really the long-term. And what's really interesting is when we took a look out at this is that the risk for reoperation for recurrence, meaning that the repair didn't work, and this is really just even the tip of the iceberg because these aren't just the ones that recurred, but only the ones that we knew about, is over 15%. And when you look at this in the context of historical data in the 1990s published by David Flum, we haven't gotten much better despite advancements in innovation and technology. And ultimately, I really think that this comes down to figuring out the right operation on the right person at the right time. In surgery, we spend an extraordinary amount of time really thinking about technical skill. We spend an extraordinary amount of time studying what happens when things go wrong in rescue. But interestingly, we spend shockingly less time thinking about the preoperative decisions that are that initial domino. And I firmly believe that if we can make better upstream decisions prior to operations, that's an untapped lever to downstream outcomes improvement and improved quality of care for patients. Who should we operate? When should we operate? What operation we should do are really our levers for change. So how do you do this? Well, first you have to get data, and you need reliable data. Unlike in Europe, we really have a paucity of population level data. We're often very reliant on administrative claims data, which is really something that's meant for billing and for resources. And while that can help you out across the population, you really are limited because you don't have the nuance in terms of the decision making or the nuance in the clinical conditions to really understand what's going on. So back in 2020, which I'd have to say was probably not the best year to start a surgical registry, I was really fortunate to be able to leverage one of our statewide population level registries to augment it and add the Michigan Core Optimization Hernia Registry. And essentially what that is is a registry of 72 hospitals in Michigan that has population level abstraction by trained nurse abstractors. And we collect variables on hernia, size, location, operative details, and most importantly, we have weighted long-term population level survey outcomes at 1, 3, and 5 years after surgery to really get at what matters most, because the truth is 30-day death and destruction aren't what defined a good hernia repair. It's really meant to be a preference-sensitive condition with long-term improvement. And if we don't know how our patients are doing, we don't know how to improve care upstream. So far, these stats are a little bit outdated. We just had our most recent data dump. We have about 25,000 patients from about 700 different surgeons and 4,000 with long-term follow-up. So let's start with the first question. Step one, what do we do together as a state? And I think it's most important when you're working on quality improvement efforts and you're trying to gain trust and you're trying to gain collaboration across the state, to start with things everybody can agree on, except for immediately going to the most contentious topics. So where did we start? We started with preoperative optimization. And this is the notion that we should wait or delay preference-sensitive operations until we can mitigate risk factors that we know preclude increased morbidity, mortality, and issues, namely smoking cessation, addressing obesity, addressing glycemic control. So we also thought this would be a great first project because nobody's going to disagree that it's a good idea to operate on those persons, but they may do it for different reasons. So step one and step two was really to identify, is this a practice gap? What are we doing in the state of Michigan? Is this worth looking at? And assess the evidence in terms of what would we need to do to reduce this gap. So what did we do? We took a look at our data and we saw that nearly 1 in 4 persons undergoing a hernia repair in the state of Michigan had a relative contraindication at the time of the operation, namely that they were suffering from obesity or actively smoking or had poor glycemic control. So we knew we had a problem. Then we took a look, and at that time we didn't have the longer term complications, but at the 30-day complications, and we saw that this associated with an increased risk of complications, readmissions, emergency department visits, and discharge not to home. And finally, we saw the economic cost to the state, which is around $60 million, and that really got our insurers' attention, which was great because in Michigan, we're sort of a single payer state, and they're very highly aligned with things that can help improve while reducing the cost of care. Then the next question was, well, is this just a couple bad actors across the state, or is this really everything? And so we took a look at this by site adherence and the percent adherence by site. And you can see in this histogram that there was a high level of variation across hospitals, but there wasn't a single hospital that was doing perfectly, and there were some hospitals doing better than others. And so whenever we see heterogeneity like this, we know that this is a good topic to study because it's not just a couple bad actors, but really prevalent across the state. Next, we wanted to really understand, well, why are people practicing the way they're doing and what are the barriers and facilitators? And for that, we kind of took to the streets and interviewed 20 surgeons from across the state in various practice with various years of experience and try to get a really great cross-sectional sample of our surgeon population to understand the decisions motivating the why. So when persons did go and violated what we know we shouldn't do, why was that happening? So at the end of this, it really came down to essentially 3 barriers to, practicing evidence-based medicine. One is the financial. Unfortunately, while we want to be a value-based care society, we're still a very much fee for service. And persons were worried if they didn't operate, there'd be loss of income, that their referring physicians wouldn't do that. There'd be reputational damage of their patients writing online about them, which then would limit other patients coming back to them. And really, there's malalignment for reimbursement. Nobody pays you not to operate. You only get paid to operate. And so there's a lot of perverse nature in the system. And so here are a couple examples. In my practice, we don't stop for smoking or diabetes. We would still offer repair. I don't get paid not to operate. And I'd love to say we're sticklers, but we're not. In this age of patient satisfaction, you send all these patients, but they come back, and when you quit smoking, they'll go find somebody else, and then you have a bad review, so you have to balance that. Second was this area of knowledge and resource access. So really, there were persons who wanted to do this, but they didn't know that it was that important, and even though they wanted to do it, they didn't have the infrastructure, so they felt disempowered to actually make the change they wanted to see. So lack of institutional infrastructure, lack of knowledge, and statewide resources. And here you can see we don't really have, optimization clinic. I wish we did, but it's more work on the surgeon's end, and I just wish we did. And so we have formal weight loss programs run by a hospital, but there's a disconnect between the outpatient and inpatient realm. So I'll recommend these things, but it doesn't really work out. And finally, it was around practice patterns and organizational barriers. So there was a lot of conflict between what the clinician thought the right thing to do is and the organization thought the right thing to do is. And you really felt that kind of on patients on the margin, where people felt somewhat forced or pressured into operating to meet various organizational expectations around RVU goals and payment goals. Local practice patterns and clinician autonomy were also big drivers. There's a fair amount of practice conformity with opinion leaders running the show. So even if people kind of disagreed, whomever was the opinion leader of the group kind of won and dictated the practice. And finally, some surgeons just said, I do what I want and I don't read guidelines, I just make it up. And they just felt that they were allowed to practice however they said fit because guidelines didn't apply to them. So what do you do? Well, the nice thing, as I mentioned about the theoretical domains framework, is that it maps really nicely to this behavior to change wheel. So you can take the different domains and you can look at these intervention functions and you can choose sort of interventions that are going to address these different barriers. So we then went and we held almost like a statewide a source where we met with surgeons and clinicians and anybody who took care of hernia patients across the state. So we could talk about these financial barriers, but also do it in a way to understand it pragmatically. There's the ideal that you want to do and the reality of what you can do, and how do we pair those things to make sure that we're setting attainable goals. So the first barrier, which was financial, one of the strategies we proposed for mitigating this was a pay-for-performance strategy. Now, in the US, a pay-for-performance strategy is really meant to be a value-based care payment alignment that goes to the organization based on reaching certain quality metrics. So for those of you savvy in the room, you're thinking, well, this is based on an individual decision, and the financial risk is to the individual, but then this is a strategy that pays the organization. So how is that going to work? And you're 100% right. And however, in our current system, there's no real way to reward or to identify non-operative decision-making. And in discussions with our insurance carriers, because this was already being deployed across the state, we felt that this was sort of the most pragmatic, better than nothing solution. Second was around knowledge and resource. And here we developed a clinician-led behavior change strategy. And I'm going to spend some time showing you what that is. But essentially, we used opinion leaders to create this sense of urgency. We provided info on local and statewide resources and addressed patient-facing barriers and address physicians' inability sometimes to know what to say to patients, how to address risk with patients, and what that looks like. And finally, for practice patterns and organizational barriers, we chose on-site facilitation. And essentially what facilitation does is align clinicians and organizational leaders. It enhances strategic thinking and leadership skills and cultivates provider champions. And the hope is that you go on-site or even external facilitation through Zoom, which can work also, and kind of reset the culture there and leave local champions who are going to continue to work once you're gone. So how do you know if any of these things work? Now, it's really interesting because in testing implementation interventions, it's a little bit different than thinking about effectiveness trials. Oftentimes when we think about is something effective, there's an endpoint, reduction in 30-day mortality, reduction in surgical site infection. But with implementation interventions, really what it's working on is the real world process. And depending on your question, you may want to evaluate different strategies, compare the different strategies, optimize strategies. And essentially what you're trying to do is determine the impact overall of the implementation strategies. So end goals you might look at is adoption, right? Not effectiveness. And because we know that we really wanted to go into an adaptation model, or what's called a randomized SMART. So SMART is a sequential multiple assessment randomization trial. And essentially what it is a multi-stage randomized trial that's really designed to inform adaptive sequence of treatments. So we can all recognize that different treatments have different burdens of implementation as well as different costs of implementation. For us, for instance, deploying a pay-for-performance metric was essentially free with low burden, but a facilitation is expensive. And we also know that not all sites and not all people need all things. So when you do these types of smarts and you're looking at adaptive sequences, what you're essentially looking is to understand who needs what when, and if somebody needs remediation because they're not hitting certain targets, is it that they need an additional intervention or are they just refractory? So basically, we're recognizing heterogeneity and trade-offs, really, in cost and intensiveness and whether or not it works. And what that essentially looks like is you'll start with a randomization intervention in one, you'll run it out for a certain period of time, you'll look for a response versus non-response. In non-responders, you'll either continue them along their additional pathway to try to better understand if they just need more time, or you'll augment them or remediate them with a different strategy to see if they just need a little bit more boost to get going. So this is essentially what that looks like across the state of Michigan right now. I showed you the 3 different implementation interventions, and this is how that, and here's how that played out. We started with about 72 hospitals, and we found whether or not they were above the certain threshold for adherence. We excluded any hospital that was at that threshold or higher. We then randomized the remaining hospitals either to receive that financial incentive alone or to receive that financial incentive in conjunction with the physician training module. We then ran that out for a year for persons in the initial financial arm. Those who responded, we continued them out. Those who didn't respond, we either continued them out on that initial financial incentive or augmented them with our clinician education module. Again, similarly, down here in this arm, for persons that started in the financial and clinician education arm, for those who responded, we continued them. For non-responders, one group continued and another one was augmented or stepped up to receive on-site facilitation. Then at the end of 12 months, you have all these cells that you can compare to understand the features of what worked when and why. So our first financial strategy, which was low intensity and easy to deploy, and I don't think it's really surprising, but that it was ineffective at scale. So when we ended up looking at what happens pre and post implementation of a financial incentive on hospitals who essentially either had it versus didn't have it, what we saw was there was essentially no difference with obesity. Interestingly, there was a difference when we looked at those hospitals who had smoking with a downtrending line. But what you're looking at here is what's called a difference in difference analysis. So it's looking at the difference of what we saw versus secular trends that were going on anyway. And there wasn't much of a difference. So while we did see an improvement, we could not attribute it to our intervention alone. And this was probably also just part of the local and statewide initiatives around smoking cessation in general. So our next intervention, which was developing a platform to address knowledge and resource gap, this was medium intensity and more intensive to deploy. And really, this was based on evidence that teaching skills modularly increases behavior change and incorporates opinion leaders. It was designed to increase the ease in which clinicians learn practice guidelines, and it facilitates learning on how to deliver the guideline. And it really follows what's called a replicating effective practices framework, where essentially it's meant to be able to plug and chug into different organizations. And this framework is often utilized when people don't have local expertise in implementation science to make sure that you can be as reducible in a rural hospital as you can in a major academic center. So essentially, this is what this ends up looking like. You can go online and you can see it's herniacalc.com and just go ahead and register. And, this was designed both incorporating patient feedback as well as surgeon feedback. And this is what the training looks like. There's a pre and post training self assessment. You can see how long each module is. You need to progress through each module before you finish. As you go through this, you'll see in our barriers to optimization, we've leveraged the voice of persons all across the state of Michigan. And here's essentially what that looks like. The other thing that you may notice was we used avatars as cartoons, so it didn't feel preachy, like we were talking down or at people. This is me as an avatar. And this was also a nice way to represent our entire patient population instead of just a homogeneous segment with different weights, different races, different genders, across the board. And then as part of this, we also created a risk communication tool. And this, of course, was also designed with everybody in mind, using patients and physicians to really understand what we're putting here is what people understand. And you can go online and play with this as well. And essentially what this does is it uses kind of the modifiable factors that we understand influence care, and it gives somebody their risk today. And then it allows you to go back in and change that. So instead of saying, oh, I don't know, lose 20 pounds, you can have somebody lose 20 pounds and show them what that means. So this is your risk today, and if you lose 100 pounds, this would be your risk tomorrow. I can tell you some of the things that we've learned initially is how do you present numbers to patients and clinicians? Sometimes what seems like a large risk reduction to us, the patients, say, oh, it's only 4%, that's great. So we've been playing around with the labeling and the percentiles here to really kind of drive home. Most interesting, though, is that this is for 30-day complications, but where we've really anchored is in the 1 year. And now you can really start calculating your 1 year self-perceived recurrence, which is, do you think your hernias come back, which is probably the most important thing about the operation. And finally, you can also do your 1 year regret, and eventually pain and abdominal wall function. So we're really excited about this. We're deploying it, and we're in the process of measuring. Early outcomes, it's been favorably received. As I mentioned, we found a couple of opportunities for refinement, mainly in how the numbers are presented. And we'll have some output, I believe, this summer or fall in terms of how effective versus not effective it is to reducing, statewide operations on persons prior to optimization for surgery. So that's in the clinical realm. So let's talk about affecting change in surgery to improve care with attention to our workforce and specifically mitigation of gender inequity locally and at scale. There's a lot of problems to solve in the workforce, and I'm only talking about one today, but I hope instead of anchoring on which problem I chose to speak on, we'll take a look at kind of the rubric and we'll take a look at the framework, and then hopefully you'll be able to take that home and address any problem that you see on your own location. So same thing as we did in the clinical workforce. We wanted to see, is there a practice gap, and what is the evidence and innovations to reduce this gap? So there's this paper published in 2016 in American Journal of Surgery, and I think it really kind of hit a curve and struck a curve at that time in terms of essentially a cross-sectional analysis of women in the academic product line, showing a tremendous drop-off really at the assistant to associate professor level. So it seemed like there was near parity in medical school and general surgery trainees and in assistant professors, but something was happening at the associate to full professor level. Now, anytime you see something like this, I think the first inclination is, well, that is terrible at other places, but that would never happen at my institution, never at the University of Michigan. At that time, we had a very progressive and forward-thinking chair, Mike Mulholland, who said, why don't we take a look at it? Because that can't be happening here. So Jen Walge, who was one of my colleagues at the time, ran a survival curve analysis of the Department of Surgery in 2005 to 2015, looking at the probability of remaining at the assistant professor level at the y-axis and year on the x-axis. And what you can see is sort of data that mirrors the national trends, is that, well, we do in fact have an issue, and that for whatever reason or not, that the females at the University of Michigan are hitting the associate professor level at decreased frequencies compared to the male counterparts. And so a lot of times people said, well, it's just because females are later to the workforce, just take your time, and it was gonna, we'll get there. Maybe, but there was another study that really kind of modeled out with the current trends in women progressing from medical school to leadership, and said that, well, for us to get parity and for us to hit at the current rate, the same rate as males in our specialty, it would really take about 100 years to get there. That's not my lifetime. That's not my kid's lifetime. That's probably not even my grandkids' lifetime. And so that's just too long. So we need to do something about that. The other thing is that there wasn't a lot of attention to sort of heterogeneity, meaning that women were all lumped into one bucket, but we do know that there's also differing elements of what it means to be female that might further, disproportionately impact some people than others. And so what we did was we chose to get together to do something about that. I've always been a big believer, all ships rise with the tide, and there's safety in numbers. So in 2016, our chair looked at us delightfully and said, fix this problem. And I said, I can't do this alone. So I was really blessed and fortunate at the time to have incredible colleagues at Michigan who, just like in our hernia collaborative, could come together and start thinking strategically about what do we need to do to not just improve our overall culture at the University of Michigan, but how can we do that at scale? You can see in this picture, many unfortunately have moved on, fortunately for them, in leadership positions, but I do miss them. John Coleman, who's the chief of vascular surgery now at Duke, Dr. Dossett, who's still at University of Michigan and running our surgical oncology division, Kate Kraft, who's a urologist, Erica Newman, who's our section chief for pediatric surgery here, Erin Perrone, who's also one of our pediatric surgeons, Erica and Jen, who's now the section chief of plastic surgery at Indiana University, and Janet Dombrowski, who many may or may not know, but is a phenomenal executive coach who's done a lot of work, across U.S. And Michigan. So the first thing we did is we wanted to understand our barriers and facilitators, just like in our hernia work. And we went and we interviewed women who both left Michigan and who still remained here to really understand barriers and facilitators to advancement. And God bless our chair, he let us publish this also. And three key themes came up for us. One was institutional culture and institutional policies. And there seemed to be some have and have nots and instructional versus other tech, a kind of blindness or lack of transparency into decision-making process. Next was relational sort of interactions. Kind of this idea of extra work females felt that they needed to do to be considered as good, if not better. And finally, individual characteristics where, people were really wondering whether they're being punished for standing up for themselves, for being different, for kind of being a squeaky wheel. And, there was good and bad examples under each of these themes. So now we understand, what the problems are. So how do we put together pragmatic, theory-informed, multi-level strategies? So, and how do we do that at scale? So in the department level, we created something called the Michigan Promise, which I'll get into in a second. In the institution, we encouraged enhanced representation on governing committees and scaling efforts. And nationally was really about research and outreach. So the Michigan Promise at the University of Michigan is our promise to advance all surgeons in the phenotype of their desire. And we really thought about that in many domains: environment, achievement, leadership, recruitment, innovation, and outreach. So let me pull apart a couple of those. Recruitment. Oftentimes in recruitment, or how things traditionally had gone, particularly in the US, is you had a job, you called your friend, they gave you a recommendation, and you hired the person for the job. When that ends up happening, it's great, and you'll probably get a great person, but you're going to get people who are very similar to you. And it also shows that you have a culture that's not welcoming of differing ideas, differing opinions, differing phenotypes. So we created a recruitment committee, and we essentially now keep our recruitments open until we have a large application pool. And when people come in, they're interviewed by a broad cross-section of our department, not just persons within their specialty in the chair, so that everybody, with a set of standard questions, that everybody can be evaluated fairly. We also have a culture crew, which thinks about how are ways that we can continue to thrive and improve our culture at the University of Michigan to make sure that everybody feels valued. I think the most beneficial thing we've done is achievement, launch, boost, exchange, and this essentially helps people get a foot off the ground. So every new faculty who comes to the University of Michigan is assigned a team, and that team is meant to keep track of their development and their aptitude to make sure they're staying on track and don't fall off. We then develop boost teams for that associate level who either wants a career advancement or needs a career reboot to do the same thing. An exchange program so that we can have our junior faculty going out and being seen, so that when we go up for promotion, they have those visiting professorships that matter so much to most. And then leadership development, we do have our own homegrown leadership development course, which teaches you everything from finance to EQ. And it's really been a wonderful addition to the department. And the important thing is you just don't do things in isolation. You have to measure and disseminate. And so here are just some examples of papers that were written leveraging and measuring the implementation and the outcomes, which have been very favorable and, again, are publicly available for anybody who's looking to emulate or replicate something in their own institution. We also went national. We really wanted to not just help fix things for ourselves, but we wanted to help fix things for others and help create a community that wasn't just within the University of Michigan, but that spanned across the United States. We also published all of our work so that people could have access to it, and created conferences. This was from our first conference, which was in 2019. Interestingly, we kept this going through the pandemic and had really phenomenal attendance in the early days, about people who just were scared and wanted that kind of community. And you can see, I think we were among the first people to do this, and just had a tremendous panels of speakers really thinking about leading and rebounding and coming from the front line, and again, creating and sharing that community. So now I have presented to you all these wonderful things that we've done, but I would be remiss if I didn't mention the elephant in the room, and it's not a shock or a surprise to you that there's been a lot of executive orders recently which limit our ability or limit research or advancement in what was historically known as the DEI space. And while I'll say that this has been an interesting time in a time of change, I do think we can still stay true to our values in this time of change and the things that motivate us. First of all, is to stay calm. When people are around you, particularly when you're in a leadership position, you really want to model calm behavior so that we can get everybody kind of back on the same pace. I think it's important to create space and opportunity to talk if people are feeling different ways about different things, allowing them to share and vent those feelings in a safe space. For areas where there may be cuts, identifying new funding streams to value what's important. We've had several areas of research which have been defunded due to areas that are no longer aligned with strategic priorities of governmental funding agencies, and I think it'll be really important to think to industry and foundations to move that forward. We can change language, but not our mission. And I think it's really important to constantly ask why and show me the policy. I think sometimes preemptive obedience versus need to react to actual laws and really try to better understand what we're being asked to do before we actually go about and do it. So with that, I want to say thank you. And again, thank you for the opportunity to give this lecture and to have this recorded for BJS.